Good evening, respected sir and ma'am, our honorable guest lecturers and my dear students. On behalf of NEOTECH Institute of Physiotherapy, myself, Dr. Shubham Parmar, Assistant Professor at NIP, would like to welcome you all. I am very grateful today since you are sparing your valuable time and energy for today's webinar. GEM Physiotherapy is co-founded by Dr. Stephen Ford and Dr. T.J. Singh, which is the global initiative for expert manual therapies. Today, we NEOTECH Institute of Physiotherapy, along with GEM Physiotherapy, are hosting a webinar on manual therapies. So today, our guest will sharing his immense knowledge regarding various manual therapies and will give a practical tips useful for the clinical practice. So now I will be handling the dais to Dr. Stephen Ford. Please,
Thank
sir.
you. Thank you very much. Thank you very much for having us. We're happy to be here. It's an honor for us. So we'll get started, guys. Let me just see if I can share my screen. Dr. Dhrumi, will you allow screen sharing? I'm getting a message that it's not enabled right now.
Yes, sir.
Thank you. Awesome. All right. Excellent. Okay. All right, give me just a sec, guys. I'm a little slow. All right, so this is us. Thank you to Dr. Parmar. Thank you to the NEOTECH Institute of Physiotherapy there in India, and to everyone that's joining us today. Let me just get out of this light here. I'm going to show you guys a quick video. Yeah. So we are the Global Initiative for Expert Manual Therapists, and we're going to provide a lecture today on manual therapy. And I wanted to title it as Manual Therapy for 2023 and Beyond, kind of talk about what manual therapy has been, what it is, and what is the future of manual therapy. So let's jump in. We're going to do some demonstrations on a lot of different things. We're going to do some static and dynamic observation, just what we can start to deduct from our patients by looking at them when they're not moving and when they're moving. We'll demonstrate some special tests, and then a bunch of manual therapy techniques, including some dry needling and some manipulations. So this is Dr. Singh and myself, as introduced. A little bit about us before we get started. So I was born in Zimbabwe. My parents lived and worked there. So I was there until I was 17. And then I came to the USA for university and beyond. I did a bachelor's of science in health at Texas A&M, doctorate of physical therapy at Texas Tech University. And then after that, I became a certified orthopedic specialist. I became certified in dry needling, and I completed a fellowship in orthopedic and manual therapy. Dr. Singh, sort of a similar background, born and raised in India, moved to Texas in 2008, had his bachelor's of science in physiotherapy from India, got a master's in neuroscience in the US. He got a doctorate of physical therapy in the US. He's also an orthopedic specialist. He's also a sports specialist. He's certified in dry needling, He's a fellow of the American Academy of Orthopedic and Manual Therapy, and he's completed a fellowship in electromyography. He's also undertaken recently a business venture where he's gone out into business for himself, and he's off to a great start. So congratulations, Dr. Singh. The first thing I want the participants to do today is to think back. Think back to a time or an event when you had somebody that provided a service for you that was so remarkable, that stood out to you so much that it left an impact on you. Maybe it was something small. Maybe somebody just went the extra mile, or they went above and beyond and just impressed you with their service, impressed you with their knowledge, or they just did something that was extraordinary. Okay. So think back. There's got to be a time, like maybe it was a doctor or a professor or a friend, sometime when someone did something for you that really, really, really stood out. Okay, so just keep that thought in your head for a bit. I want to share with you guys a couple of reviews. So on Google, if you have a Google page, people can leave reviews for you, for your services and stuff like that. And I just want to share a couple of reviews, things that people say about us, Dr. Singh and myself. But it's not just because it's Dr. Singh or because it's me, it's because we're manual therapists. This is what people are saying about manual therapists, about manual therapy. Dr. Singh's an excellent therapist. I will continue to recommend him to anyone needing physical therapy. He was able to provide me with relief that many other therapists and doctors had not. Another patient, the pain which was there for the last 10 years and almost made us opt for surgery showed instant improvement in the first sitting. And after a few follow-up sessions, she was completely out of pain. I was in pain in my low back and hip area for years. I went to doctors and chiropractors and I was still in pain. I ended up just taking medicine to manage the pain. And after one session, I was pain-free. I went in with knee pain that I had for 3 months. And after the first session, it was determined that the knee pain was stemming from my lower back. We did 2 more sessions and I didn't have any more pain. We discovered that my foot pain was not plantar fasciitis. It was in fact in part because of the sciatic nerve, and it helped my foot pain go away. The therapist was top-notch in terms of his approach. Best PT I have been to by far. So that's what manual therapy is. Manual therapy is an advanced skill set that is highly effective and can make all the difference in a patient's life. Can make a difference in a patient's life, in the lives of their families, and it can make a difference in your life as a practitioner, because you are not just touching bodies, you are touching lives, you are touching families, you are touching livelihoods. So manual therapy is a little bit difficult to define. This is one of the better definitions. I think it encompasses most of what manual therapy is. So manual therapy is an advanced specialty area of physical therapy or physiotherapy practice that is based on manual examination, treatment techniques, integrated with exercise and patient education and modalities to address loss of function, to address pain, to address wellness. Early, consistent, and skillful manual physical therapy combined with exercise and patient education is central to the orthopedic manual physiotherapist's practice. And this is a definition from the American Academy of Orthopedic Manual Therapy, where Dr. Singh and I have both completed a fellowship that has been accredited by them. So manual therapy for 2023 and beyond, let's talk about what it has been, what it is, and what it needs to become. So manual therapy as we can go way back in time, it's a whole lecture in and of itself, but we can go way back in time, thousands of years where manual therapy was being practiced. Let's just talk about the recent history where we have this profession called bone setters. Bone setters were people that did basically what we would call adjustments or manipulations. They were not precise or scientific, but they cracked stuff. They moved stuff, they pushed stuff, they cracked stuff. And it was, it's something that kind of blossomed into what osteopathic medicine is today. From osteopathic medicine, we get this branch off that became chiropractic medicine or chiropractic practice. And then also from osteopathic medicine stemmed physical therapy. And physical therapists, to a large extent, get our manual therapy techniques from the osteopathic side of things. There are some substantial differences in philosophy and in practice between the type of manual therapy that we do, which is osteopathic related, and the type of manual therapy that's done in the chiropractic realm. So when chiropractic was founded, it was believed that any and all illnesses and ailments in the human body were because the spine was not aligned, and that if you align the spine, you will fix whatever problem is there, from cancer to liver problems to, you know, you name it, fussy babies, whatever, any problem that a person can have, diabetes. The problem is a problem with the spine, and you fix it by fixing the spine, right? So that's how chiropractic was incepted. And they've softened their stance on that a little bit because it's borderline is quackery. But chiropractic is still very popular because you can walk in, get adjusted, and feel great, right? So physiotherapy, we're different in the sense that what we do is science-based, and we recognize manual therapy for what it is. And we're going to talk a little bit more about that here in a couple slides. So, but yes, there's lots of different professions that perform manual therapy. Even if they don't call it manual therapy, that's what we're going to call it. So there's lots of different professions that we share that with right now. What are the benefits and what are the shortcomings of manual therapy? Manual therapy is a powerful tool. Make no mistake, if you're a physiotherapist and you're treating outpatient, even in the hospital and stuff, sometimes manual therapy is a very powerful tool. And if you're going to be a physiotherapist, it's something that you need to excel at, and probably after your bachelor's, do some additional training and practicing and learning in this area, as did Dr. Singh and myself. My doctorate of physiotherapy was not enough. That's why I went on to specialize and do fellowship. So it's a very powerful tool. Manual therapy, if we look at short-term fix versus long-term fix, which is one of the things I love about physical therapy, because I think that we provide both. Manual therapy, when we pop and crack things, it's oftentimes just a short-term fix. It's only part of a holistic treatment plan. It might be an important part sometimes, but it's only part of a holistic treatment plan. So the short-term fix oftentimes is manual therapy, soft tissue work, muscle energy techniques, joint mobilizations, joint manipulations where we're popping and cracking things. That's usually just part of the short-term fix. The long-term fix is getting into, why did this problem start in the first place? What is the patient doing on a regular basis that's keeping this problem around? Maybe it's bad posture. Maybe it's poor lifting mechanics. Maybe they're not active enough. Maybe they have muscle imbalance in their body. Maybe they have a joint dysfunction. There's something that's contributing to the patient's symptoms. We've got to be the detective to get in there and figure out what's going on and fix that. So short-term fix is easy. The long-term fix takes a little bit more work, and it involves more of the patient. Kind of have to depend on the patient to tell us these things and to give us feedback, and then to do the work that we give them to do, right? In the way of like home exercises, posture, ergonomics, how to lift properly, and stuff like that. So let's talk about short-term fix versus long-term fix. So I have a dentist story. This guy found me on Google, called my cell phone, asked me to drive an hour to Allen, Texas to see him for his back problem. So I did. I saw him for 5 or 6 sessions, and we were doing everything. We were doing manual therapy, we were doing dry needling, we were doing exercises, stretches, everything. And he'd feel great, but then his pain would come back, and he would feel great, and then his pain would come back, and he would feel great, and his pain would come back. And so after a couple of sessions of this, I said, we need to look more into the long-term fix. I need to know what you do. So you're a dentist, right? Okay. So tell me what you're doing during the day. Tell me how you're sitting and stuff like that. And he showed me, and the posture of a dentist is horrible. And so I said, well, if we don't fix your posture, if we don't fix your ergonomics, I don't think that we're going to fix your pain, because I think that what you're doing at your work, 40 hours a week, 50 hours a week, is driving the pain, is the cause of your pain. And this guy had a herniated disc, according to MRI, and he had been suffering with his pain for a year. He's a young father, and he was planning on getting a surgery. In fact, he was this close to getting a surgery. I was his last ditch effort. I was his last resort. And after we had a conversation about ergonomics and posture and what the back needs to be happy and healthy, after a week, we did a telehealth appointment, and he said, my back has been feeling so good this week. He's like, you would not even believe the difference that it's made in my back pain from what you told me, and I've been putting that into practice. So I was giving him the short-term fix, but that wasn't fixing it. We needed to get into what he was doing every day, and that's part of the long-term fix. This is where physical therapy far outshines chiropractic. Chiropractic can pop stuff, we can pop stuff. Chiropractics are not usually experts in exercise and ergonomics and these other things. And so we can be the best one-stop shop. We can be the best place where patients can get everything that they need. So that's my dentist story. The construction worker story is the opposite. It was a one-time fix. So I walk into the clinic, and I've got this patient that was evaluated by another physiotherapist, and I'm seeing him for a second visit. And this is a combative patient. He's angry, he's grumpy, he's there under litigation for like workers' comp. He said, I was lifting something extremely heavy with a few other men, and as we were lifting it, they stopped lifting. And I was trying to hold it myself. He's like, and I felt what I think was my hip bone like shift. He's like, and I feel like it's just shifted, and nobody's listening to me. Nobody's listening to me, what I'm saying about my hip bone being shifted. He's like, I think I just need to get it adjusted. And so I said, well, you know what? Let's take a look. And sure enough, he was right. One of his hip bones was slipped up. It's called an upslip, where your innominate bone or your iliac bone is sheared upwards on the sacrum. And so I laid him on his stomach. I had one of my partners block his sacrum, and I gave his leg a big pull, and that thing popped, and he got up and started moving. And he was like, oh man, that feels great. I said, okay, well, don't get ahead of yourself. I said, come in another time this week. Let me see how you're doing, and if we need to do anything else. And the next time he came in, he said, no, man, I feel great. I think I'm done. I think I'm good. And so that also happens. I would say maybe like 5 or 10 patients a year, I pop something and we fix the problem. We don't need to do therapy, exercises, stretches, whatever. But that's like 5 or 10 patients a year. That's an extremely small percentage, because usually by the time patients come and see us, the problem's been going on for a while, right? And now the patient's compensating. We've got muscle imbalance. We've got poor movement patterns. We've got fear of doing certain activities. And maybe, just maybe, there's something that the patient is doing, sleeping a certain way, sitting a certain way, cleaning things a certain way, working a certain way, whatever they're doing, they might be doing it in such a way that the mechanics are bad and it's causing problems in their body. And so one of the things a physiotherapist does is get into the long-term fix. What do we need? Manual therapy, what is it today? Man, it's plagued by sensationalism on social media. And what I mean by that is we all see pictures and videos where people are getting cracked and it's so cool. And people are just jumping off the table in relief. You know, you got a guy in a wheelchair that gets one adjustment and all of a sudden he's running around the block. Some guy that can't stand up straight and he gets one adjustment and all of a sudden he's standing up perfectly. You know, that's sensationalism, guys, and you really have to guard yourselves against that, because while manual therapy is a powerful tool, you don't want to get into the idea that it's like the magic fix, right? We don't sell it like that. It's part of a holistic treatment. There's research, there's evidence, it's part of a holistic treatment plan. And so I hope that you guys will just take that to heart and don't get distracted or caught up in the social media, because it's sensationalism. It's just over the top, make it look so cool. Meanwhile, there's a lot of hard work and clinical reasoning and judgment that needs to happen. Just as important as when we pop and crack stuff is when not to do it. And we're going to talk about that today. Manual therapy is evidence-based. Depends on the practitioner. I think that there's lots of practitioners that don't practice in an evidence-based way. And all physiotherapists must practice in an evidence-based way. All right. I will tell you this, that as far as I know, a physiotherapist has never killed anybody performing manual therapy. But we cannot say the same about the chiropractic profession. People have died in the hands of chiropractors. Why is that? They're not paying attention to the evidence. The evidence suggests that before you manipulate a neck, before you pop somebody's neck, there are several steps, like at least 5 steps that you need to take before you pop somebody's neck. You need to get their history. You need to know, was there a trauma? Was there some kind of violent injury or something like that? You need to perform upper cervical instability testing. You need to check their vertebral basilar artery. And then there's a couple of other things that we'll do. We'll put them into the position that we're going to manipulate their neck in. And then we want to know if they have any unusual signs or symptoms, like the 5 Ds and the 3 Ns: dizziness, double vision, difficulty speaking, difficulty swallowing, or drop attacks, which is another phrase for fainting. And then the 3 Ns: numbness in the lips or tongue, nystagmus, which is the eyes shaking, and what's the last N there? Nausea, right? Like nausea. So there's several things that we have to do, and like a sieve that we have to put patients through before we can identify if a manipulation is indicated or not. Training and clinical reasoning are vital. And this is what PT school, and this is what our program is for: anatomy, physiology, biomechanics, arthrokinematics, indications when we should do it based on evidence and based on our findings in the patient's body, and contraindications when not to do it. And arguably, that's the more important of the two, right? Someone's got a fracture. Someone's got osteoporosis. Upper cervical instability, unusual signs or symptoms, systemic signs or symptoms. So, and this is where I want to see physical therapy be. This is what manual therapy should be in the future, is that a patient can go to a physiotherapist and get everything they need from a physiotherapist, right? That is conservative. So in other words, anything that's not surgical, if a patient needs it, we should be able to do it. They don't need to go to the acupuncturist over here and the chiropractor over there, and then come to you as part of their treatment plan. You should be able to do manual therapy, dry needling, and expert exercise prescription. And even beyond that, get into the patient's wellness, their fitness. What do they do during the day? How do they do their job and stuff like that? And how can we facilitate a happy, healthy body, right? So it kind of overflows into that. And then this is our vision as GEM, so that GEM PTs will be the best in the world. Expert knowledge, expert clinical reasoning, expert manual therapy skills. They'll be ethical, and they'll be expert teachers and mentors. This is post-bachelor's stuff. And so we want to see you guys come out of your bachelor's with an excellent and strong foundation. And then we recommend that either through us or through other venues, that you guys will become experts in manual therapy, that you'll become highly trained in manual therapy, and not just one approach either, not just Mulligan approach or McKenzie approach, because you actually need to know everything about all the approaches and be able to use research and your clinical reasoning to decide, when do we implement this approach? When do we implement this approach? This patient has this. Well, we should try this. I tried McKinsey on that patient, but it's not working. So I'm going to take them out of that McKinsey box, and we're going to try some other things with them that are evidence-based, right? Okay. This is India at night during Diwali. Thank you to NASA for this photo. And I love it because India is like all lit up. And our goal as GEM is to basically make this happen with awesome physiotherapists, with excellent physiotherapists. We want top-notch physiotherapists all over India so that everywhere you go, you can get good physiotherapy. Because if we don't advocate for our profession, other professions step in and patients get caught in to things that are not effective, and they're spending their money on it, and they're just not going to get a good fix. And then they end up having surgeries and taking pain meds or just living in misery, right? So we need top-notch physiotherapists everywhere for the sake of our patients everywhere, right? Okay. So we're going to do some demonstrations. Let's take a 1-minute break while I get set up. You guys don't have to go anywhere, but if you want to get some water, use the restroom, go ahead, and then we'll get started in about, let's say, 2 minutes. Okay. So we'll get started in about 2 minutes here. All right, man. Come on over here for me. Would you mind just take off your hoodie for 1 or 2 things? You can put it on the chair there, wherever you want. Right. Gonna wait just a minute for anyone that's getting water or using the restroom. All right, guys, we're gonna dive in. So manual therapy starts at the subjective history or even before. Sometimes when our patient's walking back to sit down on the plinth, on the table, on the mat, or in a chair, sometimes physiotherapists cannot help themselves. And they're already doing what? We're already observing the patient, how they're moving. Are they limping? Are they carrying their arm a certain way? And so, you know, the observation process sometimes begins before we even talk to a patient, how they're sitting, what's their affect? Are they all right? Are they sad? Are they in pain? Are they disturbed? Are they happy? And so, you know, the whole patient interaction, the whole thing is part of the process, right? Because we have to find out from our patients, if they're holding their arm like this, they're probably having a lot of pain. They might be highly irritable. And right away, those things factor into my algorithm for what we're going to do from a manual therapy standpoint. If a patient is having little pain and there's a joint restriction, we're going to pop it. If the patient has a ton of pain, now we have to know, is a manipulation the best thing or not? And sometimes if a patient is so guarded, so stiff, so protecting, if you try to force a manipulation or if you try to force manual therapy technique that's not appropriate, patient's going to have more pain. And guess what? You may not see that patient again because you hurt them, right? So expert history taking, like right from the get-go, we're learning about our patients. I wanted to demonstrate a couple of things today that I think are interesting, that I think kind of highlight kind of what is manual therapy, how do we go about discerning what needs to be done in our patients besides just, you're my patient, let me just pop everything in your body. Because that's kind of what bone setters do. I don't know if you guys have heard of this guy, Master Chris Leong. He's like in Singapore or Malaysia or something like that. And he just goes around and every single patient that he treats them the exact same way. Pops every joint in their body, makes a big deal about it on the camera, and takes their money and then leaves, right? And that, maybe it feels great for the patient, maybe it doesn't, I don't know, but that's not a long-term fix. Like, that's not what manual therapy is meant to be. Coming into a person's life and just popping everything in their body one time, right? And then touting it as if that's like a magic fix or something like that. That's not what it is. All right, so we've got Marco here. Like I said, Marco is going to be playing semi-pro soccer with the North Texas Legends. So he's offered to be our demonstration model today, one of them. So the first thing we're going to do is do a static and dynamic assessment of the shoulder girdle. So let's do that. Marco, will you come on over here? Static. Okay. So for our static assessment, we would want to look at a couple of things. We want to look at the angle of the collarbones. We want to look at his head. Is his head tilted or shifted to one side? We want to look at the tone of the muscles. We can look at the joint, the AC joint. We can look at the muscles and the shape and the positioning of the shoulders. This is from the front, right? And I'm not going to go into incredible detail because that's really reserved for our online and in-person courses, but I'm just showing you guys, this is what I would do as a physiotherapist. I want to look at the muscle definition here and on the back as well, see if there's any atrophy or spasm or anything like that. Can see there's a little bit of discontinuity here in the AC joints. This may be normal for him, or he may have had an AC joint sprain at some point. You cannot see it very well, but there's this little bit of a step off there. Okay, so maybe there's an AC joint sprain, or maybe that's just normal for him. We don't know yet. If I grab onto the acromion and I grab onto the humeral head, I want to know what is the positional relationship of the shoulder with the acromion. And if the humeral head, if more than 1/3 of that is anterior in relation to the acromion, we would call that a forward shoulder, which indicates what? Indicates laxity in the front and maybe some stiffness or tightness on the back side, the joint capsule, the posterior deltoid. If the shoulder's sitting more forward, maybe biceps is compromised, maybe labrum is compromised. There's a problem, something's going on there, right? So that's what the observation from the side would look like. From the back, there's a lot to look at from the back. First thing is, our shoulder blades should live between T2 and T8. So we find T2 and we say, no, his shoulder blades are depressed. So he might be a big, strong, beefy guy. Maybe his lats are tight. Maybe his upper trapezius muscles and levator scapular muscles are weak. Okay. So there's a variety of things that could be going on, but his shoulder blades are depressed on both sides. Okay. Most likely, I think it's because he's a strong, bulky guy. And so that's going to be important because when he goes to lift his arms up, go ahead and raise your arms up overhead. When you go to raise your arms up, the shoulder blades need to elevate is one of the things that they have to do. So they need to elevate up to C6. And if they don't, you can wind up with impingement inside the shoulder. And so just relax your arms. So even though he's depressed, raise your arms up. His right shoulder girdle gets higher than his left shoulder girdle. This side's doing all right. This side needs some work. Maybe we've got some tightness, or maybe upper trapezius is weak over here. Let your arms come down. The interesting thing is that what we observe, hey, so just have a seat. We'll grab you in a minute. The interesting thing is that what we observe, sometimes there's issues with the muscles, but sometimes there's also issues with the joints. And if there's a joint dysfunction, you can end up with muscles that are on spasm or hypertonic. you end up with other muscles that are inhibited or weak. And so that's something that we have to keep in mind throughout the process. So back to the static observation. So T2 and T8 is where the shoulder blades should live. His shoulder blades are depressed. How abducted are his shoulder blades, right? So from the midline of the body to the border of the spot of the shoulder blade, how abducted are they? Are they really far out or are they really close in? What about the rotation, the static rotation of the shoulder girdle? So if I find the spine of the scapula, it should point, and I follow the spine of the scapula, it should be at about a 60-degree angle. And his is not pointing upwards and outwards at 60 degrees, it's down. And so not only is the shoulder blade depressed, but it's also downwardly rotated, which guess what? That means more likely we're going to have what in the shoulder? Impingement. Okay, it's much more likely that we'll have some impingement in the shoulder. So this can lead to shoulder issues. So if he was here for shoulder pain, we would want to fix that. You know, we would want to work on that. We would want to fix that. We can look at the medial border of the shoulder blade. It's not sticking out, but if it was winging, if the medial border is winging, that's middle trapezius, right? If lower border is winging, that's like serratus anterior and lower traps, right? So that's just an example of static observation. Dynamic observation, let's go up. I want to see elevation of the shoulder girdle to C6. I want to see posterior tilting of the shoulder blade. We want to see the shoulder blade upwardly rotate. We want to see it upwardly rotate. We want to see this inferior angle of the shoulder blade do what? I want to see the inferior angle of the shoulder blade make it to the midline of the body. If it does, serratus anterior is doing a good job. If it doesn't, serratus anterior is not doing a good job. This is basic static and dynamic observation of the shoulder girdle. There's more to see and more to talk about, but I just wanted to give you guys that. I guess let's go ahead and do a gait assessment. Marco, let me have you turn around. You guys aren't going to see a lot in this video, but let's talk about gait assessment. Let me just have you walk back a couple of times. So in gait assessment, we're looking for, does he lean to one side? Are his knees extending? Is there an early heel rise where there's, tight calves? So gait assessment is something else that we do, and that helps us to formulate a hypothesis for what we might need to do from a manual therapy standpoint. Okay, I'm sure you guys get gait analysis and gait assessment in PT school. So stand facing this way. Let your arms come out of your pockets. Raise your arms up overhead. One more thing I wanted to show you here when we're looking at shoulder flexion is, does the thoracic spine extend or does it flatten? And if you look at Marco's right here, he still stays kind of rounded out. That's pretty typical. Most of our patients are going to be stiff in the thoracic spine. Most patients that we treat, we should be manipulating thoracic spine. If it's a neck, if it's a shoulder, if it's a back, if it's a hip, if they have any kind of nerve symptoms in the arms or legs, there's research, there's reasoning as to why we should manipulate the thoracic spine, which we're going to do here in just a minute. Okay. I want to show you guys a couple of more tests, and then we're going to do some treatment. Okay. Marco, if you will come lay on his back. Head right here. Yeah, I guess let's do head first and then feet. Okay. We are going to do what's called segmental mobility testing. Have you guys ever heard that term before? Segmental mobility testing. So basically, we're going to take an area of the body and we're going to move the joints in such a way that we can determine if the joint is stiff, if it's moving normally, or if the joint is hypermobile, if it's moving more than it should. Because if it's stiff, we need to loosen it up. If it's normal, we're not going to worry about it. If it's hypermobile, we shouldn't be popping it. We should be doing stabilization exercises, right? So let's check out Marco's neck, and we'll see if we find any stiff joints. And if we do find some, we'll talk to him and just see if a neck manipulation might be appropriate. I already know that Marco over here has had at least 5 concussions. So there's some red flags there. It doesn't mean we can't pop his neck, but it means that we need to know his history, his symptoms. We need to check his neck ligaments. We need to check his vertebral basilar artery and make sure that he's not having any symptoms from that before we would manipulate his neck in order to do so safely. Okay, so let's take a look. So in segmental mobility testing, let me take off all my stuff here. First thing I'm going to do is I'm going to palpate his occiput, and I'm going to palpate for the tone of his suboccipitals. How do his suboccipitals feel from side to side? His right suboccipitals are crazy tight, and his left ones are a little bit not as bad. Left ones are not as bad. Do you get any headaches on this side of your head?
Yeah.
Only on this side or both sides?
Not just on this side.
He gets headaches on this side. And the suboccipitals already told me that, right? What nerve comes out through the suboccipital muscles? Greater occipital nerve. And cervicogenic headaches will feed in a ram's horn pattern this side of the head, right? So he needs some neck work. Whether or not manipulation is safe or not, he needs some neck work. We already know that. And I also know that he has residual symptoms from his concussions. He can get a little bit, has a hard time like driving sometimes. Sometimes he gets to where he's, gets a little bit of brain fog, brain fatigue. And so actually today, when we're done with the lecture today, I'm going to do like a neuro screen on him and try to get him some exercises to get him out of these concussion symptoms. But back to segmental mobility testing. So I already know that the suboccipitals are tight on the right side. For the OA joint, what I'm going to do is I'm going to support the head, and using the nose as an axis, I'm going to move the head to that way, and I'm going to side bend it that way. And it does not side bend that way as much as it should. It side bends that way plenty. So we have a restriction in the OA joint. I would do some other testing to determine what side it is, but since the right side muscles are lit up, it's probably the right side, right? Let's just be honest. Now I'm going to come down the back of his neck in the middle of it. And the first big bony prominence that you feel going down the central neck is the C2, because C1 doesn't have a spinous process. C1 is more of this ring-like structure, and it doesn't have much of a spinous process. So the first spinous process that we feel, that's our big landmark, is C2. So I'm going to wrap my fingers around C2 like this, and then I'm going to hug the neck. I'm not going to squeeze it, but I'm just going to take up the slack from the skin and the muscles, and I'm going to hug C2, and I'm going to move C2 side to side. And then I'm going to do the same thing at C3, move it side to side, C4, side to side, and down. So C2, we're going to move it side to side. Stiff on the right. C3, also stiff on the right side. C4, C4 is not as bad, but it's also stiff. C5, C5 is all right. C6, C6 is nice and loose. C7, C7 is going to be stiffer because it connects to the thoracic spine, but it's stiffer on the right than it is on the left. The whole right side of his neck is not happy, basically. Okay, the whole right side of his neck is not happy, basically. Okay, I want you guys to pin my video so that it's large. Dr. Dhrumi, is that better now?
Yes, sir.
Okay, thank you. Thank you for that. Heads up. Okay. Okay. So we did side glides. So hug the neck. Don't be loose. You need to hug the skin, compress the skin to the muscles, compress the muscles to the bone. And right when you've got the muscles compressed to the bone, you keep that compression and you move side to side. I don't want you kind of wiggling the neck and wiggling the muscles and wiggling the skin. You've got to be compressed to the segment that you want. Okay. So that's how we check the neck. I'll also do a side bend, a full side bend to the right, rotate, full side bend left, rotate right. He should have 35 to 45 degrees here. He does not. That tells me that C1, C2 is stuck on the right side. We're going to side bend this way. Going to rotate to the left and look at that difference. Okay, I have to show you guys this. All that needs is a pop. All that needs is a simple pop, but we're not going to do it yet. So side bend to the left, rotate right. He can't do it. His nose is still pointing up towards the roof. When we side bend this way and rotate to the left, he's got his 35 to 45 degrees of rotation easy. Okay. So that's segmental mobility testing of the neck. Since we're thinking about popping Marco's neck here, we're going to do our due diligence and we're going to check his upper cervical ligaments. So the first thing we're going to do is we're going to check the transverse ligament of atlas. So I'm going to take his head and his C1, and I'm going to hold on to his C2, and I'm going to try to move C1 and his head independently of C2. There should be no laxity there. If there is laxity, then transverse ligament of atlas has been damaged or interrupted, and you would expect cord signs, arms and legs symptoms, numbness, tinglies, those kinds of things. It would be an uncommon finding because usually they're clinically unstable at that point. We would not see them in the clinic. So I don't expect that to be positive, but we need to check it. So I'm going to hold his head. I'm going to support his head with my shoulder, and I'm just going to lift C1 and his head off of C2. And as soon as I lift up C1 and his head, C2 comes along with it. So that ligament is intact. No problems there. The next thing we're going to do, usually I do this laying down, but so you guys can see it, we'll do it sitting up. Marco, can you sit up facing that way? To check for the alar ligament, you need to palpate the spinous process of C2 and then side bend the head. And as you side bend the head, the spinous process of C2 is going to move in the opposite direction. So if I side bend this way, spinous process of C2 should kick out that way. So I'm going to try to hold on to C2 and I'm not going to let it kick out and side bend the head. There should be no laxity. The moment the head side bends, C2 should kick out, and I should not be able to stop C2 from kicking out. And I can feel C2 moving. Very nice, nice and crisp. Let's check the other side. Yeah, same thing on this side. I can't stop C2 from moving. It's moving great. Last but not least, let's do our vertebral artery test. We lay back down for me. Vertebral artery test and Jefferson compression fracture test. So again, I don't expect a compression fracture patient to walk into your clinic, but if they've had a substantial head trauma, you might as well check, just relax. I'm going to take a lobster grip. I'm going to find his C1 and I'm going to push his C1 like this and see if there's any 5Ds, 3Ns, dizziness, double vision, bilateral, quadrilateral, paresthesia, anything unusual, right? So let's give that a little push. Anything with that? Any pain, discomfort, anything, any weird symptoms? Okay, no. Okay, so I just squeezed his C1. And you got to know where C1 is, right? From a palpation standpoint, we teach that. Next thing we're going to do is our vertebral artery test. So here's what we're going to do for vertebral artery test. I'm going to have you turn your head to the right, keep your eyes open, and count from 10 to 0. Out loud.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
And anything with that?
No.
Anything? So I was watching his eyes for nystagmus, but if he has any dizziness, double vision, difficulty speaking, difficulty swallowing, if he falls asleep, if his arms or legs fall asleep, anything usual or strange, we would want to know about that. Okay, so we'll do the same thing to the other side. Count from 10 down to 0.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Any problems with that? Any symptoms with that? Okay, cool. So would you be all right if I provided a quick stretch to your upper neck over here? Maybe help out with these migraines a little bit. All right. And probably even before that, what we're going to do is a thoracic spine manipulation, thoracic spine and CT. So give yourself a big hug, opposite arm on top. I'm going to roll you over. I'm going to put my hand under your back. We're going to start kind of down here and then work our way up. Okay. Breathe in, breathe out. Nice. In, out. Nice. Breathe in, breathe out. Good job. Okay. Thoracic spine and CT done. That was good. We got some good ones. You ought to feel kind of loose after that. All right, let's do neck. So I want to manipulate C2, C3 over here. Try to help out those upper cervical headaches that he's having, those cervical headaches. No way I can teach a manipulation in one short video, but I'll talk you guys through it. I'm going to find C2. That's the big spinous process, the first one that you feel. I'm going to contact C2 posterior lateral. I'm going to guide the head into a side bend, side glide at C2. Yeah, you already feel that, don't you? Yeah. And then I'm going to slowly rotate the head, take up the slack. Right now, his head can't move any more to the left, which means we're at the barrier. We need to have the barrier. We need to find the stiffness, find the tightness. And then with a precise, high velocity, low amplitude thrust, in other words, very small, but very quick, we're just going to give that a little pop. Okay, 1, 2, 3. Okay, I'm going to come the other side. Nice. Let's do maybe, I don't want to do the whole neck, but let's do maybe 1 or 2 more spots. So where's the worst of it? I think in here. All right, so be loose, be loose, be loose. Okay, I'm going to come this way. Okay, good job. Okay. There's a soft tissue technique that I would do on him. I'm not going to spend 5 or 10 minutes of our lecture doing it right now, but it's called suboccipital release. So because he's had hypertonic suboccipitals over here as a result of what's going on in his neck, and certainly this is contributing to headaches, migraines, and other issues, I want to dig my fingers into the suboccipitals on both sides. And then I'm just going to provide a gentle traction force to the neck at the suboccipitals. And then to make it even better, what I'm going to do is, Marco, I want you to just tuck your chin to your throat very gently, super gently. Engage that and hold. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Relax. Do you guys know what we're doing here? So we're engaging some agonists, some of the opposite muscles to the suboccipitals, in order to turn off the suboccipitals. So if we take the opposite muscle group, the flexors, and turn them on, we should get reciprocal inhibition of the suboccipitals. So tuck your chin slightly. Good. And then I'm just keeping pressure on those suboccipitals. This is a great manual therapy technique for headaches, for neck pain. If a patient has like cervical radiculopathy, you just gently park your fingers underneath the occiput. And you don't have to do the chin tucks, but I like to do the chin tucks, especially when the suboccipital muscles are tight or hypertonic, and then just relax. Okay. We're going to do another technique here. We're going to just loosen up your upper neck. So we're going to do a occipito-atlantal manipulation because we felt that his OA was restricted on the right side. So I'm going to cup his head. I'm going to park my right hand underneath his right occiput. And then what we're going to do is we're going to provide a quick vertical force or superior force just to try to help loosen up his neck, get him back in the game. All right. So your job is just to relax. Are you okay like that? Okay. 1, 2, 3. Good. One more time. Okay, good. There are several different handholds and positions that we can do any of the manipulations in. So any manipulation that we do, there's probably 3 or 4 or 5 different ways to do it, different positions to do it in: standing, sitting, laying on your back, laying on your stomach, laying on your side. So for demonstration purposes, we're just showing a few techniques today, but you guys tune into our manipulations course and our body part specific courses, and we'll show you guys everything. Okay. I want to show a couple of other techniques. So let's do lumbar and SI, hip, ankle, and foot. And then I think we'll do a brief dry needling treatment. And then I've actually got another patient that we'll do some stuff on. So hope you guys are enjoying. We're going to keep going. Will you lay on your side facing that way? So if we do me a favor, will you take the AC and like crank it down to like 68? All right. This is a basic SI manipulation. It's not as specific. So if I really wanted to hit SI only, I would do a different technique, but this is not a bad technique for beginners. We're going to try to pop the SI joint right here. And the reality is, the better your technique, the more likely you can hit SI joint. But if your technique is sloppy, you're going to be hitting lumbar spine, sometimes even thoracic spine with this technique. Bend your knees for me, Marco. Actually, you know what? Bend the top knee. Let me have this hand there. I'm sure you guys have seen this one before. My left hand and his left hand are holding on. So you hold on to my wrist and I'll hold on to your wrist. I'm going to hold his arm there. We're going to come to his SI joint right at the PSIS. 1, 2, 3, and thrust. Nice. Let's do the other side. So give me your right hand, and then left hand can just rest there. Hold on to my right hand, hold tight. Put my hand on your PSIS. Hold tight there. Push, push, push. 1, 2, relax, 3. Nice. Okay, lay on your back. We're gonna do hips. Yeah, just stay like that, yeah. So I'm going to take this hip, just relax, relax, relax. I'm going to put the hip in its open pack position, 30 degrees flexion, 30 degrees abduction, 20 degrees of external rotation, so that I can distract the hip. 1, 2, 3, do a couple of little oscillations here, and then we're going to thrust. Boom. Feel that nice distraction of the hip in the socket. Nice distraction there. Let's do this side, same thing. Oscillate a couple times, oscillate, 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 and manipulate. Good stuff. Can I take your shoes off? Go take your socks off for me too, man. So the next thing we're going to do is segmental mobility testing of the foot. Yeah, we do it everywhere. So let me show you my segmental mobility testing of the foot real quick. Okay. So this foot, I want to know how it's moving. I want to know about all the joints in the foot. Are they moving or not moving? Are they stuck or are they moving too much? So the first one we're going to do is dorsiflexion. Let's dorsiflex that foot. Does the patient get 10 degrees? If they get 10 degrees, they're good. If they don't get 10 degrees, either it's because of the calf or it's because of the talocrural joint, and it's hard to tell which one's which. So here's how we do that. Let's say he doesn't get 10 degrees. Okay. It's either the calf or it's the talocrural joint. So what I'm going to do is I'm going to test the talocrural joint in that position. And if the talocrural joint is stiff, then it's what's limiting the dorsiflexion. If the talocrural joint moves well, like his does, then it's going to be more the calf, okay? If talocrural joint was stiff, we can go hand over hand and manipulate it. Hand over hand, lean back, and we're going to provide a thrust and just manipulate just the ankle. If I do a big slow pull, I'm going to manipulate, I'm just going to pull his body off the table. It needs to be small and quick. Ready? 1, 2, 3, boom. Boom. Okay. Let's do segmental mobility testing of the subtalar joint. Okay. So we're going to grab the calcaneus and I'm going to wiggle it around. I want to see lots of inversion, 20 to 30 degrees of inversion. And I want to see 8 to 15 degrees of eversion. So I'm just wiggling the ankle. And it feels like his mobility of the subtalar joint is good, goes well both ways. If it was stiff, we could mobilize it or manipulate it. Let's take the talus. I'm going to hold on to that. There's a bony prominence right here called the navicular tuberosity, and that's the navicular bone. So I'm going to grab the navicular bone, grab the talus. I'm going to move navicular bone on the talus. And I want to know how well it's moving. Kind of wiggle it. See how I'm wiggling it? So there's navicular bone. Now I'm going to stabilize navicular and we're going to move cuneiform. Okay, cuneiform. I'm going to stabilize cuneiform. We're going to move the first metatarsal. Okay, now I'm going to bend the big toe back. I want to see 70 to 80 degrees of big toe extension. I'm going to hold on to the intermediate cuneiform and I'm going to wiggle the, let me just turn this around for you guys. I'm going to hold on to the intermediate cuneiform and we're going to wiggle the second metatarsal. Okay. Follow that second metatarsal up to the midfoot there. Stabilize the midfoot, stabilize that cuneiform. And then I'm going to wiggle second metatarsal on that. See how that's moving. A lot of stress fractures in this bone in runners and athletes. And it's because in part, this joint can get stiff. So we want to make sure that's moving well. His is moving okay. I'm going to stabilize the lateral cuneiform and we're going to move the third metatarsal. Good. I'm going to wiggle the cuboid. So cuboid's right here. I'm going to wiggle it up and out, down and in. See how cuboid's moving? It's moving well. If it was stiff or stuck, we would manipulate it. Okay, cuboid's moving well. I'm going to block cuboid and I'm going to move fourth and fifth metatarsals on the cuboid. I'm going to move it side to side like a windshield wiper. And I'm going to move it up and down, checking the mobility between the metatarsals and the cuboid. Okay, so that was segmental mobility testing of the ankle and the foot. And if you're treating an ankle or a foot patient or anything above that in the kinetic chain, we need to be able to do segmental mobility testing, because if there's stiffness and problems in here, it's going to cause problems higher up the chain, right? Okay. All right. Marco, are you okay if we do a dry needling demonstration?
Yeah.
Do you care where we do it? We could do it in the calf or the thigh, which you probably wouldn't feel very much. We could do it in those muscles at the top of your neck that were really tight and it'd probably help a lot. You want to do that?
Yeah, let's go ahead and do that.
Let's do that. All right.
Can I
So,
put my shirt on?
yeah, put your shirt on. Yeah, no, it's chilly. Put your shirt on and then I'll get you set up. All right. So we're going to do a live dry needling demonstration for the back of the neck. We'll do suboccipitals. We'll do neck extensors. We're going to do upper traps, at least those. We'll see. I'm going to go easy on you. So we're going to be pretty gentle with the treatment, okay? First time I do dry needling on anybody, I do a pretty easy, gentle, light treatment. There's a lot of different things you can do with the needles. You can manipulate them. You can run electricity through them. You can turn them. You can put a lot of needles. I'm just going to do a very basic, very light treatment. First time I do it on anybody, that's how I usually do it. I want to see how they tolerate it. And also too, you know, less is more. If you can get the job done, go ahead and lay in your stomach. If you can get the job done, you know, going easy and going basic, then why would you use 30 needles in 30 minutes? Okay. All right, so what I'm going to do is I'm going to take my alcohol wipe. This is under the realm of manual therapy as well. I'm going to wipe the back of the neck. I'm going to wipe anywhere I'm going to put a needle. We're just going to go ahead and wipe that, either with alcohol wipe or cotton with alcohol, just something. Gloves on. Here's my needles. They're individually wrapped and sterilized, so we don't have to worry about, cleaning them or contamination or anything like that. This is our target side, this right side of the neck over here, okay? So what I'm going to do is I'm going to palpate the occiput, right? There's the occiput coming down, there's the occiput. So here's my suboccipitals. And if you look at the anatomy, you could divide the neck in half. So let's take this half, for example, up until the mastoid process. And then you could divide this further into 3 parts. And you would get basically the 3 different suboccipital muscles that are there. So I'm just going to come in here and check each of those sectors, right? If you break it down into thirds, each of those sectors, and they feel pretty okay until we get to this one, the most medial sector. So what I'm going to do is now I'm going to splay my fingers. So a little window, tap my needle, angle it towards the occiput. And I've now penetrated those muscles all the way to the bone. And you just relax. Okay, you're doing good. Very easy, very basic. Okay. The moment that the needle hits that muscle, it's going to affect several different things. There's a local effect, there's a spinal cord reflex, and there's a systemic effect as well. That's a whole one-day lecture on the physiology, the effects of dry needling and how it works and stuff like that. So you guys can tune into our dry needling course. But basically it has a lot of different effects, and it can be a very powerful tool as well. So we hit the suboccipitals. Let's come down to the middle of the neck where you can see it, you can feel it over on this right side of the neck. The cervical extensors are really, really tight and angry. Okay. So we're going to hit the cervical extensors. Okay. Needle in, needle out. The needle does not have to stay in. The moment the needle hits the muscles, the effect that it's going to have has already been set into motion. So like in acupuncture where patients sit with needles inside them for 20, 30, 45 minutes, that's not necessary. Okay, it's not necessary. Let's do upper trapezius. So I'm going to expose upper traps over here. I'm going to pinch that muscle in my hand. I'm going to splay my fingers apart, and we're going to hit upper trapezius. I know you guys can't see too great, so that's why you got to come for the in-person course. Okay, and then what I'm going to do is I'm just going to hit that upper trapezius. I'm trying to get it to twitch, because if it twitches, that will give a really good release, but I think we're going to go ahead and stop there. It's a lot. Being needled is a lot, and don't expect too much from your patients. My recommendation is go easy the first time. So that's it. That was my dry needling treatment for Marco. We hit his suboccipitals, his cervical extensors, and his upper trapezius. If I was treating him in real time, like in the clinic, I would check maybe a few more areas, just looking for trigger points or muscles that are tense or hypertonic. But that was if you're just going after the big and important muscles, that was it. So that was our dry needling demonstration. And Marco, consequently, I think that we are done for the day. We can do one of two things. If you want to hang out for about 15 minutes, yeah, I can do a neuro exam for your concussion stuff, or if you want to.
Yeah.
Okay,
Cool.
Okay. Why don't you just sit and chill then? and I'll do a couple things with Soph, and then I'll get with you. Okay. All right. All right. So have you got us? Are you ready for me? All right, cool. Come along. So I'm going to have you stand right here. All right. So this is Sophia. Thanks for coming, Soph. The first thing we're going to do is I'm going to watch you walk to the mirror and back. You can do that 3 times.
Okay.
Yes, normally. We're going to pretend that Sophia is a sciatica patient, that her sciatic nerve is going crazy, right? So the first thing I would do is I would watch her walk. Go ahead, keep going. And then since we're dealing with sciatic nerve issues, right, we're wondering, is there nerve root irritation? Is there a joint dysfunction? Is there a disc herniation? Is there a space occupying lesion that's irritating her sciatic nerve? Go one more time. Is there a sacroiliac joint dysfunction? A lot of times in patients that have that sciatica or those sciatic symptoms, they'll have a Trendelenburg on the affected side, right? So we would expect to see a Trendelenburg gait, or that's when they're walking and the pelvis is dropping. They stand on the affected side and the pelvis is dropping towards the unaffected side. Okay. So we're going to pretend like Soph has sciatica. So I watched her walk. The next thing that I would do, so stand facing that way. We want to check range of motion. Sophia, can you bend forwards? All the way, all the way, all the way. And then I'd want to see her back. Is it moving well? Is it rounding out nicely? Is there any pain in the leg, sciatic nerve? Is there any pain at the SI joint? And then come back up. We could do repeated flexion and we could do repeated extension. So if you've got a patient with pain running down the leg, what the research says is you should check repeated extensions. So hands on your hips and lean back. And then I want you to do 20 of those. Okay. So I would have my sciatic patient do repeated extension and standing enough times until they can tell me if their pain is getting better, if it's staying the same, if it's getting worse. If it's better or same, we'll keep going. If the pain is getting worse, we're going to stop. If extensions are helpful, pain will get less, the back will be looser, and we'll see pain come up out of the leg, and the pain will move up out of the leg into the hip or into the back. Okay. So if repeated extensions helped her, we would use the McKenzie approach as part of her treatment. If repeated extensions did not help her, maybe it didn't help, or maybe it increased her pain, then we're going to go to plan B, right? So we'll hit the table. Sophia, come on your back. There. Let's say that while I was checking out Sophia, she told me that she's got pain like right here. Pain is right there. Okay. And the pain doesn't go below the knee. So now I'm thinking maybe we got more like SI joint stuff going on. And so for SI joint, what we would do is we would do a test. We do a couple of tests, but the ones that I'm going to demonstrate for you today, one of them is a supine to sit test. So with the patient laying on their back, I'm going to give her a little pull, and then I want to check her medial malleoli. I want to see if they line up. I want to see, are her legs the same length or are they different? Okay. So I would want to know, is the left leg longer? Is right leg longer, or are they the same? Okay. That's in supine. That's laying on her back. And then I'll say, give her my hand, say, Soph, take my hand. I'm going to have you sit up. And then in sitting, again, we want to see what happens to the feet. Does the pain, and there's several different things that can happen. On the painful side, the legs could be the same length and they could stay the same length. On the painful side, the leg could be short, and then when she sits up, it becomes longer. That's posterior rotation of the hip bone. The leg could be longer and become shorter when she sits up. That's anterior rotation of the hip bone. The leg could be shorter when she's laying down and shorter when she's sitting up. That's an upslip, and we're going to have to pull it down. Could also be an inflare. The leg could be longer, and when she sits up, it's still longer. that would be an out flare or a down slip. And this is just the hip bone. We're not even talking about the sacrum and what can happen at the level of the sacrum yet, right? So you guys can see already that this is potentially a really deep, complicated rabbit hole, and it is. So one of the things that makes it hard to become a manual therapist is that some of this stuff is complex. Besides just the skills to pop stuff and the clinical reasoning, some of the stuff is complex, but you got to do it. It's your job as a physical therapist. You got to do it. So let's say the right leg was shorter when she's laying down and shorter when she's sitting up, which indicates an upslip. So I'll show you how we would correct an SI upslip. So can you lay on your tummy? Do you mind if I give that leg a pull? I'll be nice. I'll be nice. You know I'm nice. Marco, can I borrow you for a sec? All right. Marco, you're going to be my assistant. So here's what I'm going to have you do. Sophia, he's going to put his hand on your bottom. So Marco is going to come put his hand on Sophia's sacrum, not in the middle of it on the coccyx. If the sacrum is a triangle, if the sacrum is an upside down triangle, and this area is called the inferior lateral angles, the ILA, the inferior lateral angle. I'm going to have Marco come and block the inferior lateral angle, not the coccyx, inferior lateral angle. So you're going to put this part of your hand just like that. I'm going to put one hand there, one hand on the table, and basically just keep a straight, stiff arm right here and just kind of hold her in place for me. You don't have to push too hard or anything like that, but just hold her firmly for me. Thank you. Right there, straight elbow, lean in, got it. Okay, all right. Then I'm going to take Sophia's leg. We have to lock out the hip because I don't want to manipulate the hip. I want to manipulate the SI joint. So to lock the hip out, we're going to put it in its closed, packed position, which is abduction, extension, and internal rotation. I'm going to lean back, take up the slack. So just rest your head. And 1, 2, 3. Thrust. Thanks. You're good. Relax. Okay. And that's how we would correct an upslip. SI joint's pretty stable. You got to tug pretty hard. Okay. All right. I think I'll, for the sake of time, we'll probably go ahead and call it for today. I know we're already running about 30 minutes over. I was going to show you guys some corrective exercises and stuff like that, but I think you guys just have to catch that next time or catch that in one of our courses. So, Dr. Dhrumi, Dr. Singh, can I turn it over to you guys real quick? Let me just show one more slide here. Let me share this last slide for you guys, and then I'll turn it over. Share screen, desktop, PowerPoint. Okay, so before I let you guys go, so GEM, we do have a cohort. So we have a class a month that we teach. It's online. And then Dr. Singh and I will be coming to India a couple times to do in-person classes or hands-on workshops. The hands-on workshops can be done separate and distinct to the cohort, but the classes are highly, highly complementary. And our PTs always do much, much better in the hands-on training and just in general with their integration of the information and the clinical reasoning and stuff like that when they attend the online courses. And the online courses are great. They're highly interactive. We teach anywhere from 6 to 8 hours over the course of Saturday and Sunday, which is a lot, but it's a lot of good substantial information. You guys get PowerPoints and recordings, so you can work through the material at your own pace and have access to that material. So we did already start our first cohort, but we have rolling admissions open for just a little bit longer. So if anybody else wants to join in, it's not too late. We can give you the recording from our first course. Get in touch with Dr. Dhrumi. She can help you with that. From GEM, from me, I just want to thank you guys for letting us come, for listening in, for tuning in. Thank you to NEOTECH Institute, the Physiotherapy School. Thank you to Dr. Parmar. And Dr. Singh, I'll turn it over to you now. Thanks.